All right, thanks for that introduction. I'll go ahead and get started since time is of the essence. We're a little behind. So first, my disclosures. I have funding from Merck and iCuris. So just to give you an overview of how we're going to approach talking about infection in the transplant patient, first I want to review some of the basic principles of transplant infectious diseases, and then we're going to move on and we're going to talk about important pathogens in the kidney transplant patient. So I think that includes CMV, BK virus. We'll talk about fungi and hepatitis C. And then lastly, I'll conclude by talking about urinary tract infection and asymptomatic bacteria in kidney transplant patients. So first, the basic principles. Transplant recipients are susceptible to opportunistic infections and community-acquired infections. You need to remember both sides of the coin. Infections can result from exposure to a much lower number of organisms than your typical host. So, all it takes is a couple bites of the food that's contaminated with salmonella and they're quite sick, whereas your normal host can eat that sandwich and kind of get some diarrhea and get over it. So in this sense, these patients can be the canary in a coal mine. That means they can be the first people to show up to your practice with something that's going to outbreak in the community like salmonella or influenza, norovirus, et cetera, because they have a more dramatic illness and they get it more easily. So the inflammatory response to infection is suppressed in transplant patients. This is a really important point to remember. These patients have attenuated signs and symptoms of infection. So this means that your transplant patient who calls you and says, I don't feel right, I've been feeling under the weather for several days, my temperature's been 100.2. You really need to assess that patient, particularly if you're in an academic medical center and it's July. Sometimes these patients can get accidentally sort of pushed off by new trainees. I saw a case a couple years ago of somebody who had a pheresis catheter in for rejection and called in with those exact symptoms. And she was actually bacteremic with MRSA, but only had a temp to 100.2 and just kind of felt off. So you have to remember that. And then lastly, the transplant recipient with infection typically has a really high burden of organisms once infection is established. So while it doesn't take much to get them sick, they don't have normal host defenses. And so once they have the bug in their body, they can be teeming with it. So this has infection control implications. For example, at my institution, if you have dermatomal zoster and you're a transplant patient, you're still maintained on precautions that we typically use in normal hosts for disseminated zoster because you have more of the virus around, you're more likely to transmit it to others. So in 1998, Jay Fishman and Bob Rubin described the basic principles of transplant infectious diseases in this nice review article for the New England Journal. They were the transplant ID people at MGH at the time. I think it's worth reviewing their concepts because they're still salient today to the transplant patient. So one of the cornerstones of their argument is that you need to know the net state of immunosuppression of the patient. So this includes knowing the dose and duration of immunosuppressive medications, like how much prednisone for how long. In this day and age of monoclonal antibodies and biologics, you also need to think about things like rituximab. How long ago did they get that, if they got that for antibody-mediated problems, because that one can last longer. So it's a little more nuanced now than it used to be with biologics that can hang around for a long time. You also need to understand if the person has mechanical factors, though, that increase their infection risk. And in this patient population, I'd say the most common thing you run into is that they have an indwelling venous catheter. Either they have a leftover tunneled catheter that they were temporarily getting dialysis through, or has been used for pheresis, or maybe they have a leftover PD catheter early after transplant. All of those mechanical things in their body can set them up to get infection around the catheter, or in the case of an intravenous catheter, a bloodstream infection. So it makes them more vulnerable to that particular kind of infection. And then lastly, you need to sort of think about, well, are there any infections that are making them more vulnerable to certain other infections? HIV, I should back up and say, is the most common, or not the most common, it's the classic example of an infection that leads to other infections. But in transplant patients, the one that I would say is most common and problematic is CMV. When people have active CMV infection, it definitely sort of boosts their vulnerability to other opportunistic infections. And I've certainly seen people develop PCP pneumonia if they're not on prophylaxis when they have a late CMV reactivation. Other infections that can increase your risk are things that we knew in med school, but we often forget. For the respiratory viruses, so influenza, for example, can really predispose you to getting a bacterial pneumonia or even invasive aspergillosis. There's increasing data that those two are related. So the other thing that they sort of point out in this basic principles article is that you need to think about epidemiologic exposures in these patients. So, we always in ID think about the recent exposures. So did you eat in the restaurant where there's salmonella or a norovirus outbreak? Or do you have a grandchild who has influenza? That sort of thing. But in this patient population, you really need to think about the remote exposures that the person had that can reactivate. And so the classic example of that is tuberculosis, right? You can be exposed, get over it, and then it reactivates when you're put under immunologic stress. But other things that fall into this category, endemic mycoses like histoplasmosis and coccidiomycosis, if you've lived in the right area of the country. And then even thinking more broadly, there's a lot of viruses that we meet in our early life that can reactivate after transplant. CMV is the most obvious one of these, varicella zoster, hepatitis B. So if people have had that and cleared it, it can reactivate after transplant. So you really have to think about all those exposures in these patients when they're presenting with infectious complications or you think they have an infection. So another really important point, which sort of gets back to understanding the net state of immunosuppression, is understanding the immunosuppressant itself. So with biological and targeted therapy, understanding the mechanism of that agent is really going to help you understand what kind of infections they're going to get related to that exposure. So for example, rituximab, as you all probably know, is an anti-CD20 antibody. So it takes out B cells. And when you do this, you're impairing the ability for somebody to respond to a vaccine, right? Because they can't have the B cell response. It then leads to the plasma cells that make the antibodies. So when many studies have shown that when you vaccinate people in the first 6 to 12 months after they've gotten a dose of rituximab, their response to a vaccine and even a recall antigen is really subpar. So you have to remind them they might not be that well protected by their flu vaccine. And then longer term, it can cause hypogammaglobulinemia. Another example that I really love, because it's very elegant, is eculizumab, the C5 complement inhibitor. It's approved for atypical hemolytic uremic syndrome. So effectively, this means you have a terminal complement deficiency. And you all may remember from medical school, people with congenital terminal complement deficiency are at risk for meningococcus. And that's exactly what we see with this drug. It increases your risk for having a meningococcus infection by about 2,000 times. It's a really profound change in these patients. So you have to vaccinate them before they get the drug. And you have to remember, in people with atypical hemolytic uremic syndrome, they get it like every month or two for years potentially. And so sometimes those people who've been on it for a really long time can break through their vaccine and get, a non-vaccine strain. And so you have to be really careful about these patients with that disease entity. So the last thing to know is that mTOR inhibitors, mammalian targets of rapamycin, so that includes sirolimus and everolimus, have anti-CMV activity, which is a great benefit of those drugs. So sometimes ID providers will say, can you switch this person's immunosuppression if somebody keeps having trouble with CMV to see if just this change in immunosuppression helps prevent that particular infection. So let's move on and talk about a case. This is a 35-year-old CMV negative woman with a history of lupus who gets a kidney transplant from a CMV positive donor. She gets prophylaxis with valganciclovir and trimethoprim sulfamethoxazole. 8 days after transplant, which is 2 days after she was discharged from the hospital, she presents with a fever to 102 without any localizing symptoms. So get your clickers ready. Which is the most likely source of her fever? A, PCP pneumonia, B, CMV reactivation, C, infected perinephric hematoma, or D, cryptococcal pneumonia. So go ahead and ring in. All right, I'm gonna cut you off now. Didn't turn it off. Okay. So most people agreed with what I think, which is infected perinephric hematoma is the best. Whenever anyone asks like an ID question about a transplant patient, everybody always wants to answer CMV, but the answer is not always CMV. It is probably the most important infection, but it's not always CMV. So we're just going to go directly to my next slide. Whoops. There. We're going to go directly to my next slide to sort of rationalize through this. So this person's like 0 to 1 month out from transplant. And when people show up with a fever in that sort of time frame, typically the infections that you see are nosocomial. So like they can have bacteremia or candidemia related to lines or UTIs, nosocomial pneumonia, or it's procedure related. So wound infection, perinephric abscess, this infected perinephric hematoma, this is something that I get asked to see definitely with some frequency. So those are the people showing up early after transplant. And that's why that's what she has. She was on CMV prophylaxis. She was on PCP prophylaxis. So it's not going to be either of those. And cryptococcus, you usually have to have a little chronicity of immunosuppression to get really sick with that, even if it's a reactivation event. So it's the patients who are 1 to 6 months after transplant that show up with the opportunistic infections. That's when you see CMV if the person's not on prophylaxis. That's when you see VZV if they're not on prophylaxis. This is when you see aspergillus if it's going to happen, PCP if they're not on prophylaxis. And then people who are recently treated for rejection, even if they're further out than 6 months, I always think of them as being in this middle column, this category, if you just got something for rejection. And that risk probably lasts a few months. And then if you're more than 6 months out from transplant, you haven't had any rejection, that's when you see these community acquired infections. So that's when the person shows up with salmonella, norovirus, strep pneumo. Interestingly, that's usually when people show up with cryptococcus. That one is, you can either sort of have been exposed to it before transplant and it's there and you just can't see it and it slowly grows over time on immunosuppression, or you have a new exposure and you get an acute new infection. But you have to sort of be out in the world, walking around things where you're inhaling bird droppings and that sort of thing to get it. All right, so let's move on and talk about important pathogens. And we're going to start with a case. This is a 57-year-old man with 4 days of malaise, fatigue, and low-grade fever. His medical history is end-stage renal disease due to polycystic disease. He had a deceased donor renal transplant 9 months ago. He's CMV D+, R-, and he got 6 months of prophylaxis. Those are his medications now. On exam, his temperature is 100.3. The rest of his vitals are normal. He has a little bit of tenderness over the transplant kidney, but nothing else that stands out. His labs are notable for a mild transaminitis. His white count is 2.1. His hematocrit's normal, and his platelets are 81. His urinalysis is unimpressive. The most likely diagnosis is A, transplant pyelonephritis, B, CMV syndrome, C, EBV-associated post-transplant lymphoproliferative disorder, D, CMV nephritis, or E, disseminated BK infection. Go ahead and ring in. All right. Can we get up to 50? Okay, perfect. I'm going to cut off the voting. All right, let's see what you thought. All right, so most people thought it was CMV syndrome, which is the right answer. And we're going to talk about that now. So I kind of made up this terminology, disseminated BK virus infection. I mean, when you detect BK in the blood, of course, it's everywhere. But really, that's an asymptomatic infection typically. It's not nephritis and it's not pyelonephritis because like the UA is unimpressive. His kidney doesn't hurt that much. And then PTLD, I haven't really given you anything that would make you think that's what it is. Okay. There we go. Okay, so let's talk about CMV. Post-transplant CMV reactivation is associated with direct effects and indirect effects that lead to the complications. So the direct effects, the first thing that can happen is you get asymptomatic viremia. And the only reason we care about this is because we want to treat it before it becomes symptomatic. So what are the symptomatic manifestations? CMV syndrome, which I mentioned is the most common. So typically that includes leukopenia or cytopenia. Sometimes people have low platelets, fever, malaise, And sometimes people have abnormal LFTs with it. So that's what this case patient looked like. Gastrointestinal disease is probably the next most common thing we see. So it can be anywhere from, mouth to anus. People oftentimes will either have colitis, or we've seen gastritis, esophagitis. Pneumonitis is rare in this patient population, and retinitis is very rare. The indirect effects are that these patients can have increased susceptibility to other infections and probably also PTLD, which is something we had already covered. It probably increases their risk for rejection because the CMV stimulates their immune system. And then lastly, there's increasing data that it probably increases their risk of death or cardiovascular events in the long term. So we're talking over decades. There's a large database study that showed increased risk of death, mostly due to cardiovascular events and graft failure, in those who are at high risk for CMV who were not on prophylaxis compared to people who did get prophylaxis. And we're talking about their risk of death, like 10 to 20 years out from transplant was higher than the people who got prophylaxis. So transplant recipients who are seropositive for CMV or receive a transplant from a seropositive donor are at risk, but the highest risk is when the donor is CMV positive and the recipient is negative. Because basically what you're doing is you're taking someone, you're giving them a whole bunch of immunosuppression that's new, and you're giving them an organ that harbors this new infection that their immune system has never seen. So you weakened their defenses and you're giving them a new infection all at the same time. So up to 60% of people without prophylaxis in this category will reactivate. The timing of the risk without prophylaxis is highest in the first 3 to 6 months, but in people who get prophylaxis, the CMV risk is going to be highest in the first 3 to 6 months after the prophylaxis ends. So it pushes it out, but it also reduces the overall rate of development of CMV infection. So if you give prophylaxis for 6 months, then the number of people who develop that complication after the 6 months ends is fewer than if you didn't give anything. This is called delayed onset CMV infection. And then you sort of resume CMV risk when you treat people for rejection, you have to remember. So how do you predict risk? This is like kind of a hot area of research right now. So there's a couple articles that have come out recently looking at the absolute lymphocyte count. So one of them is, suggested that if you look at the absolute lymphocyte count of the patient at the end of prophylaxis, if it's low, that means those people are at higher risk. And there's, different groups have found different cutoff points. The absolute lymphocyte count is a really inexpensive test, right? It's just a CBC with a diff and you can calculate it. Whereas this other thing that people are looking at, CMV specific assays of T cell immunity, or a T-spot for CMV, is an expensive test, but that may also be something that could predict who's at highest risk when prophylaxis ends. So there are studies ongoing, and it's something to pay attention to over the next few years. So how do we prevent CMV? Universal prophylaxis is what most centers in the US use. You treat everybody who's at risk for CMV with antivirals for 3 to 6 months, and you stratify them often for duration based on whether they're D plus R minus or in the other category. D plus R minus typically gets 6 months and the others can get 3 months. This prevents early reactivation and the indirect effects of CMV, but it is associated with delayed onset CMV, which we see most often in the D plus R minus population. So preemptive therapy. This is when you routinely monitor the CMV virus load weekly or biweekly for the first 6 months. And then if you see viremia, you treat it before they develop symptoms. It's associated with decreased antiviral toxicities and cost, but it probably doesn't prevent those indirect effects. So again, there may be this increased mortality risk like far out from transplant in those patients. So how do you treat it? Ganciclovir and valganciclovir are the mainstay of treatment. Ganciclovir is only available IV in the US now, and valganciclovir is the oral prodrug of it. The side effects, you all probably know, both of these drugs can cause some pretty terrible dose-dependent leukopenia and neutropenia. When leukopenia due to valganciclovir develops, though, you really need to continue the treatment dose. You should not reduce it or stop it just because of leukopenia. The only time you should adjust the dose is when the person has a change in their kidney function such that they need a lower dose or a higher dose if they have improved function. So CMV treatment and prevention with suboptimally dosed valganciclovir can lead to resistance. And that puts you into just this terrible place because the options for treating resistant CMV are just worse. It includes foscarnet and cidofovir, which are IV medications that are both nephrotoxic. Foscarnet can cause some terrible electrolyte abnormalities. And then there are some other unusual side effects like iritis that cidofovir can cause. The other drug out there is letermovir, which we'll talk about. This is a new drug, which sounds great, except it hasn't been studied for treatment. We really don't know how to use it for treatment at all. And so we just don't have enough information about that drug to use it in patients with resistance yet. So given the morbidity associated with CMV and the toxicities, this is a really active area of drug development. So the first drug we should talk about is letermovir, which targets the CMV terminase, so the viral particle can't exit the infected cell. A phase 2 open label study of letermovir for 14 days in kidney transplant patients showed good safety and efficacy. So more recently, there was a phase 3 placebo-controlled trial looking at it for CMV prevention in stem cell transplant patients. It was a success. The drug is approved for that indication specifically. Right now, there is a phase 3 double-blind study of letermovir versus valganciclovir that's ongoing in kidney transplant patients. So we need the results of that study to understand how we might use that drug in kidney transplant patients. And more importantly, this drug is really expensive. It's not easy to get somebody's insurance to cover it. So I think if this is the right answer for prevention in kidney transplant patients, we need the study to show that so that insurance companies will sort of be able to cover it. Because right now it's not something that there's good data for. The role of letermovir in treatment is unclear. That's also something that needs to be studied. So maribavir is another drug that targets the viral kinase. And so this has been studied in a phase 3, looking at it versus oral ganciclovir in liver transplant patients. And they used a relatively low dose of maribavir, and it did not work for prevention. So people have sort of stopped studying this drug as a preventative. But what is ongoing is that there was a phase 2 treatment trial looking at higher doses of it for treatment of resistant or refractory CMV, and 67% cleared at 6 weeks, which is comparable to valganciclovir in clinical trials. The main side effect of this drug is dysgeusia. So people have this terrible metallic taste in their mouth shortly after they take the drug. It is oral, though. It doesn't cause cytopenias or other sort of hematologic toxicities. There is currently a study underway for resistant or refractory CMV therapy now that I believe is a phase 3 because they found the dose that they want to use. So let's move on and talk about BK virus infection. BK virus is a polyomavirus. Greater than 90% seropositivity is seen by about age 4. So we think it's mostly a sort of an asymptomatic pediatric infection. JC virus is the other clinically important polyomavirus you may hear about. BK, though, causes most of the polyomavirus-associated nephropathy in kidney transplant patients. There's only just sort of a smattering of cases due to this JC virus. It can also cause hemorrhagic cystitis and very rarely nephritis in stem cell transplant patients in the early post-transplant period. So what about the nephropathy in kidney transplant patients? The estimated prevalence is 1 to 10%, and it's usually in the first year after transplant. 95% of this problem is seen during the first 2 years after transplant. And in the absence of intervention, up to half the people who have it will lose their graft. Some studies have focused on risk with specific immunosuppressants, but what really washes out with this is that when you have an increased level of immunosuppression, regardless of the agent, your risk is probably increased. It's diagnosed histologically on biopsy with immunohistochemical stains, but it can be patchy when it's early, so you can miss it on the biopsy. But the development of nephropathy due to polyomavirus is preceded first by persistent high-grade viuria and then viremia. So more people will get viuria than develop viremia, and more people will develop viremia than develop nephropathy. But the viremia is a good way to screen people for this. And it can happen in up to 20 to 30% of kidney transplant patients that they get some level of viremia. So how do we treat it? The best treatment is reduced immunosuppression. It's been a variety of agents have been looked at, most notably fluoroquinolones. So there's been a randomized placebo-controlled trial of levofloxacin for prevention and a separate one for treatment of BK viremia, and both showed no difference between levofloxacin and placebo. So this drug does not work for this indication. Other things that people have looked at in sort of less rigorous studies include cidofovir, brincidofovir, leflunomide, IVIG, statins. None of them have shown a consistent benefit. So what you need to do when you see somebody what you need to do to sort of prevent this in your patients is to sort of screen for it. You need to find it and then intervene early. So the kidney guidelines and also the American Society of Transplantation recommend screening with BK virus loads. So one of them recommends monthly for the first 3 to 6 months, and then every 3 months until 1 year. The American Society of Transplantation is a little more aggressive. It says monthly for the first 9 months and then continue every 3 months for the first 2 years. And those with viremia can be treated, meaning you can reduce their immunosuppression. All right, so let's move on and talk about fungal infection. We'll do a case. This is a 65-year-old man with bipolar disorder, atrial fibrillation, and end-stage renal disease from lithium who had a kidney transplant 4 years ago. He presents with fevers, malaise, body aches, and nausea. His medications are listed there. When you see him, his temperature is 100.2. His exam is notable for an irregular cardiac exam, but is otherwise normal. His labs, he has a very mild transaminitis. His white count is normal. Blood cultures that are drawn for the fever grow yeast in 2 of 4 bottles. So the most likely pathogen is A, Aspergillus fumigatus, B, Rhizopus pucilis, C, Cryptococcus neoformans, D, Stenotrophomonas multifilia, or E, Aspergillus niger. So go ahead and ring in. This is an ID question that only ID people can love. I know, it's a little detailed for the nephrologist. All right. I'm going to cut you off now. Let's see what people thought. Okay, so most people got it right. They thought it was Cryptococcus. Very good. So the reason that Cryptococcus is the right answer here is because Aspergillus and Rhizopus, which is one of the mucorales, all grow as mold. So those aren't yeasts. They wouldn't grow in blood as yeast. And Stenotrophomonas, I'll remind you, is a bacteria. So there's only one yeast on this list, and that's Cryptococcus. So what about fungal infection in kidney transplant patients? The Transplant survey is this very useful study that tracked invasive fungal infection in all solid organ transplant patients at 15 centers in the early 2000s. And what they found is that the cumulative incidence of fungal infection in kidney transplant recipients in the first 12 months after transplant was 1.3%, which is the lowest of all solid organ transplants. So kidney transplant patients kind of stay out of trouble from this mostly. The most common fungal infections in kidney transplant were Candida at about 50%, and then Cryptococcus is the next most common, followed by Aspergillus, and then endemic mycoses like Histo and Coccidiomycosis. So what about Candida infection, the most common one? It's often related to procedures or hospitalization early after transplant, or with medical complications or rejection later on. In the Transnet survey, Candida albicans was the most common, followed by Candida glabrata. And I'll remind you, glabrata is the one that can be resistant to fluconazole, which makes it a little bit of a pain to treat. Fungemia was the most common invasive manifestation. And mortality in patients with Candida infection was low in kidney transplant patients relative to other solid organ transplant patients. So what about Cryptococcus? Cryptococcus is often late after kidney transplant, as I indicated before. The median time in one cohort was 20 months. There's another older cohort where the median time was something like 4 or 5 years. So it can really happen late after transplant. And the spectrum of disease, you can see just fungemia, meningitis, you can see isolated pulmonary infection. Soft tissue infection is quite uncommon. This is an example from a lymph node aspirate. So somebody who had a pulmonary focus and a mediastinal lymph node that was aspirated. Pulmonary infection is relatively common in this patient population actually, and is often asymptomatic. Sometimes people will have a screening chest x-ray for something and a pulmonary nodule is seen and they are referred for like a VATS to take it out because people are worried it's lung cancer. And then it's removed and the pathologist says there's yeast here. So usually that is Cryptococcus in this patient population. How do you treat it? Lipid formulations of amphotericin or fluconazole are indicated depending upon the site of infection. 5-flucytosine with lipid amphotericin is used for central nervous system disease, and that can be kind of hard to tolerate for these patients. So back to the case, yeast is identified as Cryptococcus. The patient's treated with liposomal amphotericin. Lumbar puncture is normal, so he doesn't have meningitis. So he's switched to fluconazole at discharge, and his tacrolimus is adjusted. Apixaban is changed to warfarin, and he has INR and tacrolimus monitoring scheduled. And it's this last line that's really important that I want you to remember. So you have to remember in this patient population, azoles are really interact with a lot of drugs through the CYP system. Voriconazole and posaconazole tend to be the worst. Fluconazole and isovuconazole tend to have the least interaction, but all of them can lead to increased concentrations of a lot of different medications that these patients may be on. Obviously, the ones that stand out are tacrolimus, cyclosporin, sirolimus, and everolimus. But a lot of these other drugs can be really problematic, especially the anticoagulants, right? We don't really know how to dose apixaban with some of these drugs. So it's hard to know, but you will over-anticoagulate someone potentially. And so with warfarin, you also have to adjust the dose, but at least you can follow levels a bit more easily. So initiation or cessation, you have to remember when the person stops the azole, requires dose adjustment and close therapeutic drug monitoring. So I think that where people run into trouble is if they give like a 5-day course for thrush of fluconazole and then they forget to readjust the medications at the end of those 5 days. And the person can end up with rejection in that scenario. So let's talk briefly about hepatitis C. This is an exciting area for ID providers. The management and prognosis of hepatitis C has changed profoundly with the availability of direct-acting agents to treat hep C in the last 5 years or so. You can now pretty much cure hepatitis C in more than 95% of people with 8 to 16-week courses of interferon-free medication now. So concurrently, the opioid epidemic has led to an increase in otherwise healthy deceased donor kidneys. And so this sort of leads us to have changing ideas about hepatitis C, both in the donors and the recipients. We can use, the question is, can we use infected organs that might previously have been discarded to address the organ shortage? So the challenges that you can foresee with this are that you have to think about drug interactions with the hepatitis C medications, and then how do you dose them in somebody who, for example, gets an infected kidney but has delayed graft function. So their kidney function is really poor initially. So you have to think that through before you embark upon this. So first, let's talk about the infected kidney transplant person who's listed, so doesn't yet have their transplant. Should hepatitis C therapy be delayed for this person until they get their transplant? And will having a hepatitis C positive donor recipient scenario impact their outcomes? So first, this has been studied in kidney transplant recipients between 2000 and 2012 at a large center. So this is before we had all these nice agents. And what they found was that hepatitis C positive recipients of hepatitis C positive kidneys had significantly shorter wait times and improved graft and overall survival. So this answers the question, are they going to do worse if they get an infected kidney? Well, it seems like no, actually. And then more importantly, this other fairly clever study from a couple years ago looked at outcomes in 2 different large centers. They were both Mayo centers, and they had the same kidney transplant program scenario, except that one center treated people with hepatitis C before or at the time of listing, and the other one waited to treat people until after they got their kidney transplants. And so they compared the outcomes at the 2 centers. There was no difference. And then they compared them based on time from kidney transplant listing to getting your kidney. And this is the percentage of people who get a transplant. And you can see the center that treated the people early before they were listed, not that many people are getting transplants. Whereas the center where they waited to treat, lots of people are getting kidneys because they're eligible for these hepatitis C infected kidneys. No difference in the outcome as long as you treat it. So what about the D+R- scenario, where you're taking an infected kidney and putting it into somebody who's never had hep C? This was first reported from the group at University of Pennsylvania in 10 people. And what they did was they gave preemptive therapy. So they had all viremic donors with genotype 1 hepatitis C, and they gave them to the recipients and followed their hepatitis C virus load, and all of the recipients became viremic within 3 days. So preemptive they had to start therapy like right away. So they started therapy very, very early after transplant, and they were treated with this drug because this is the Merck drug that was supporting that trial. And they all sustained virologic response at 12 weeks. And then since then, there's been follow-up data on all these patients at 12 months out. They're all cured of hepatitis C, and their eGFR and quality of life is similar to non-hepatitis C infected donor kidney transplant recipients. So then this group at Hopkins did a similar study, except what they did was they transplanted 10 people with hepatitis C infected donors of various genotypes, not just one, and they treated them all up front. So they just gave them therapy because they assumed they were all going to get infected. And all of these patients also achieved sustained virologic response at 12 weeks. So where does this leave us? This approach is likely to be standard in the future, right? There's good success in these early studies, but we need to sort of figure out which agent should we use, because now there's pan-genotypic agents, so they treat all genotypes of hepatitis C. And some of these regimens have become shorter, but more importantly, in thoracic organs, there's a recent study in the New England Journal that showed that they basically got away with giving them 4 weeks of treatment. And the thoracic organ recipients did not get a hepatitis C infection. They did not have problems after transplant. So maybe we can treat them really briefly after transplant if we give them a hepatitis C infected kidney. I think studies will show, and we'll know in the next couple of years how we want to handle this best. So in the last 3 minutes, we're going to talk urinary tract infection and asymptomatic bacteriuria, which is a very common problem. So first a case, it's a 53-year-old woman who presents for routine follow-up, and her transplant was 10 months ago. She's CMV D+R-, and she finished her valganciclovir and her sulfa prophylaxis 4 months ago. She's no health complaints today. She feels great. Those are her meds. Her labs are normal. She has a urine culture collected at the visit, and now it's growing greater than 10,000 colonies of Klebsiella. It's ampicillin resistant, cefazolin resistant, ceftriaxone susceptible, sulfa resistant, Cipro intermediate, nitrofurantoin resistant, levofloxacin resistant, amoxicillin clavulinate susceptible, tetracycline susceptible. The patient has no medication allergies. The best management is A, treat with Cipro, B, treat with nitrofurantoin, C, resume trimethoprim sulfamethoxazole prophylaxis, D, admit for IV ceftriaxone, or E, I really don't like any of these answers. So ring in quickly so I don't go over time. All right, I'm going to cut you off now. Let's see what you thought. Okay, most people agreed with me. I hate all those options except for E. It's just a terrible scenario. I don't want to treat this infection. Is it an infection, or is it just bacteria in her urine? So UTI is a common complication post-transplant. It happens in an estimated 23 to 75% of transplant patients. I think the reason for the range is that some studies include asymptomatic bacteriuria and some include UTI that's symptomatic. The risk is highest in the first 6 months. Risk factors include being a female, pre-transplant hemodialysis, diabetes, and having nephrolithiasis. The most common pathogens are listed there. By far and away, it's E. coli. And how do you prevent it? So trimethoprim sulfa prophylaxis can reduce the frequency of UTIs. And current guidelines suggest 6 to 12 months of either that drug or nitrofurantoin as an alternative. But what about my patient? She had asymptomatic bacteriuria. So a lot of centers will check these urine cultures at routine follow-up. But why? She felt fine. So should you treat it once you're in this scenario? The pro is that you'd prevent symptomatic UTI, pyelonephritis, or even sepsis or bacteremia, right? The con is that you're going to expose this person to antibiotics, which leads to collateral damage. And then the next time you check her urine culture, it's going to be even more resistant, right? Don't you feel like you start chasing these people into these super resistant bugs because you're exposing them a lot? So 2 recent studies have looked at this, and actually there's a third that came out after I submitted these slides a month ago. So the first one looked at 112 patients with asymptomatic bacteriuria who were treated 22 were treated and 90 were untreated. And there was no difference in the later development of symptomatic UTI or reduction in GFR or other endpoints. So basically no difference if you treated it or not. The more impressive study here is the next one that I'm going to mention, which is 112 patients that were randomized to have treatment or observation. So this was a randomized trial. And what they found was that there was no difference in later development of lower urinary tract infections, so cystitis, pyelonephritis, rejection, development of C. diff, or graft function. So it didn't matter if you treated them or not. And the more recent study, the third one that I would list now, was also a randomized trial that was very similar to number 2, actually, found no difference. So new Infectious Diseases Society of America and American Society of Transplantation guidelines recommend against screening these people if they're asymptomatic. You don't want to have to be put in the position where you feel like you want to treat them. And they recommend that you don't treat them. So the cutoff or the caveat to that is that they're talking about people who are at least 1 to 2 months out from transplant. So in summary, when you're evaluating the kidney transplant recipient with infection, timing and rejection history is going to be key to figuring out what kind of infection they'll have. CMV is a really important pathogen, and when prophylaxis is used, it'll happen after the prophylaxis ends. BK virus is a really significant cause of graft failure, and you need to monitor people for viremia. Fungal infection is relatively uncommon after transplant, but if you're treating one with an azole, you need to remember your drug interactions. Hepatitis C, waiting to treat Hep C in an infected recipient is reasonable, it turns out. And hepatitis C D plus R minus transplants will likely become mainstream in the future. We just need a little bit more data. And then UTI and asymptomatic bacteria are common, but guidelines suggest asymptomatic bacteria should not be screened for or treated in these patients. And with that, I will thank you for your attention.